So if you're assessing a patient with diabetes and he's coming here for the follow-up, the thing that you would like to assess his first is his presenting complaint. If there is a presenting complaint, you will write down his presenting complaint and deal accordingly. For instance, that the patient does not have any presenting complaint, he's just here for the follow-up or for the refill. Your objective is to two or three things to find out as a quick follow-up assessment. Number one is whether there is a complications or not. Complications for the symptoms, you will ask about the blurry vision, you will ask about for the nephropathies, you will ask about urine output, you may ask about confusions, you may ask about edemas, peripheral edemas, or there is shortness of breath, there is dyspnea. This is for the cardiac complications. For the nephropathies also, you will also need to ask about the progressive dyspnea, you need to ask about the progressive edemas. And then for the neuropathies, you will ask about the numbness. For the visual retinopathies, you will ask about the visual symptoms. So symptomatology related to neuropathy, symptomatology regarding to nephropathy, symptomatology regarding to retinopathies. So this is how you, on the basis of symptoms, you will see that whether the patient is developing some complications or not. Is there any ulcers there which are not healing? So is there any weight loss or not? Weight loss is important. It can give you the idea that if the patient has persistent hyperglycemias, he will have weight loss. So this is one objective of your follow-up, to see the symptomatology, to find out whether they have complications or not. Number one. Number second thing is whether the patient is compliant with his medications. Number one, whether the patient is compliant with his lifestyle, whether the patient is compliant with his diet. If the patient is not compliant with his diet, whether is it a diet, whether is it a lifestyle, whether is it a medication. So no matter if the patient has hyperglycemia or is uncontrolled diabetes, so you first need to find out whether the problem is within the drug or is within the lifestyle modifications. For instance, the patient has hyperglycemia and you see that okay, the patient is taking glucophage metformin twice daily and he still has hyperglycemia, you may want to increase the drug. But before you do this, you make sure that the patient does not have is compliant with the medications, is compliant with the lifestyle, is compliant with the diet. And then you need to, this is the subjective evidences. Now you will have to have some objective evidences to find out whether the patient has diabetic complications or not. For the complications, you will do objective evidences is you will do some creatinine, urine for microalbuminuria for nephropathies, and you can do cholesterol. You should do eye checkup. You need to know whether the patient has eye checkup is done yearly basis or 6 monthly basis, depending on what is the problem and what are the things that are there. You need to educate the patient or reinforce the patient about the diet, about the lifestyle, about the drug compliance. And then you also need to educate the patient about the hyperglycemia symptoms, the hypoglycemia symptoms, if the patient is on insulin particularly. And if the patient is taking sulfonylureas, you also need to counsel or educate the patient about the high risk of developing hypoglycemia. So for instance, if the patient is not eating, he has to eat something after he takes sulfonylureas specifically. Metformin doesn't matter, but metformin does not have hypoglycemias. The other thing is you will do hemoglobin A1C. You also ask the patient to have serial blood glucose monitoring on different occasions, FPS, fasting blood sugar levels, RBS for the meals, pre-meals and post-meals on different occasions. So you will have a better idea of hyperglycemia problems. There is an objective of hemoglobin A1C. Hemoglobin A1C will give you only the 3-month average, right? But when the patient is coming to you, so for instance, but this hemoglobin A1C is not going to give you a real time understanding. So you must have to have these reflow readings, which is called fasting blood sugars, random blood sugars. So both of them can give you the real picture. The hemoglobin A1C will give you the past results of the average, but for the real scenarios for 2-3 weeks, you need to have some serial blood sugar level monitoring so that you can comment on whether you want to step up or you want to step down. The targets for the controlling would be hemoglobin A1C less than 7 and FPS 130, or RBS from 150 to 180. This is the limit for the RBS. RBS is random blood sugar level post meal, 2 hours post meal. FPS is fasting blood sugar levels, 8 to 10 hours of fasting. And then you need to educate you. Now this is for the assessment. Now we will do the examinations. You will approach the patient, whether is it a diabetic patient or a hypertensive patient. You can use the approach of head to toe examination. You need to, from head to toe, you need to see the hair distribution, you need to see the skin distribution, skin conditions. Is there any cracks? Is there any ulcers, or what is the condition of the skin generally for the hands, for the foot? So skin conditions. Then you need to do eye examination for retinopathies. You can do oral examination for oral candidiasis. You can start with the chest examination for any vesicular breathings, for any crepitations. Then you will do CVS examination for any heart examination, for any added sounds, for any pleural effusions, for any heart failure symptoms. Abdominal examination for ascites or any masses. And then you go to the foot examination. The whole foot should be examined with inspection, with palpation, and with skin colors, any ulcers if they are there, what are the grades of that ulcers. You can do proprioception. You need to do the touch sensations to comment on diabetic neuropathies, diabetic nephropathies, diabetic neuropathies or vasculopathy. And you also need to educate the patient about the foot care. The patient should have a good foot care, comfortable foot care. He has to examine the foot on its own. And then you need to arrange for a follow-up, whether it be a weekly or a monthly or a 3-monthly basis, depending on what is the status of this diabetes or hypertension. This is how you're going to approach the patient, follow-up patient with diabetes or in hypertensive patients. Okay.